Hello everyone and welcome to Blood and Hematology YouTube channel. The second video of Acute Myeloid Leukemia section presents the diagnostic criteria and blood and bone marrow morphology of AML subtypes M0, M1, and M2. AML with minimal differentiation accounts for less than 5% of AML and occurs at any age, most often in infants or older adults. Blasts comprise at least 20% of the bone marrow or peripheral blood cellularity without evidence of myeloid differentiation by morphology and cytochemistry. Diagnosis is based on immunophenotypic evidence of expression of myeloid-associated surface antigens. In AML M0, blasts comprise 20% or more of bone marrow nucleated cells and 90% or more of non-erythroid cells. Blasts are negative for myeloperoxidase and Sudan black B staining by cytochemistry. Flow cytometry studies usually demonstrate expression of myeloid-associated antigens CD13, CD33, and CD117, as well as CD34, CD38, and HLA-DR. The M0 granular blasts may be small to medium in size with high nuclear to cytoplasmic ratio, dispersed chromatin, variably prominent nucleoli, and scant, occasionally basophilic cytoplasm. The blasts lack cytoplasmic granules and may appear similar to lymphoblasts. The blasts in AML M0 usually resemble AML M1 myeloblasts, or acute lymphoblastic leukemia L2 lymphoblasts. In a minority of cases they resemble the monoblasts of AML M5. Peripheral blood smear usually demonstrates granular blasts and thrombocytopenia. Bone marrow biopsy usually demonstrates a hypercellular marrow with sheets of blasts. 20% or higher of all nucleated cells, and 90% or higher of non-erythroid cells are blasts. Associated dysplastic features in erythroid and megakaryocyte lineages may provide indirect evidence that a leukemia is myeloid, non-lymphoid. Dysplastic features are present in up to a quarter of cases. AML without maturation accounts for approximately 15 to 20% of AML and typically occurs in adults, but it can occur at any age. AML M1 shows morphologic and/or cytochemical evidence of myeloid differentiation, but without evidence of significant myeloid maturation. In AML M1, blasts comprise 20% or more of bone marrow nucleated cells and 90% or more of non-erythroid cells. 3% or higher of blasts are positive for myeloperoxidase or Sudan black B. Bone marrow maturing monocytic component, promanocytes to monocytes, are less than 10% of non-erythroid cells. And bone marrow maturing granulocytic component, promyelocytes to polymorphonuclear leukocytes, are less than 10% of non-erythroid cells. Flow cytometry studies show no specific immunophenotype in AML M1. Blasts are typically positive for CD13, CD33, CD117, and myeloperoxidase. CD34 and HLA-DR are detected in approximately 70% of cases. M1 blasts are usually medium to large in size with a variable nuclear to cytoplasmic ratio, a round or oval nucleus, one or more nucleoli and cytoplasm, that sometimes contains or a rod, a few granules or some vacuoles. In AML M1 the blasts are predominantly type 1. In some cases, the blasts are indistinguishable from L2 or even L1 lymphoblasts. Peripheral blood smear usually demonstrates blasts and thrombocytopenia. Or rods may be present. Peripheral blood film of a patient with AML M1 showing a large type 1 blast and thrombocytopenia. Peripheral blood film of a patient with AML M1 showing a type 1 blast with prominent nucleoli and a normoblast. Bone marrow biopsy often demonstrates hypercellular marrow with sheets of blasts, although normocellular and hypercellular marrow cases are not uncommon. Blasts comprise at least 90% of non-erythroid cells, and 20% or more of all nucleated cells. Fewer than 10% of the leukocytes show maturation to the promyelocyte stage or beyond. Bone marrow smear of a patient with AML M1 showing hypercellularity. A basophilic normoblast and a plasma cell are noted. Bone marrow film of a patient with AML M1 showing blasts type 1 and type 2. Bone marrow film of a patient with AML M1 showing positive myeloperoxidase stain. The M2 subtype accounts for about 30% of cases of AML and occurs in all age groups. In AML M2, blasts comprise 20% or more of bone marrow nucleated cells and less than 90% of non-erythroid cells. Bone marrow maturing granulocytic component are 10% or more of non-erythroid cells. Bone marrow maturing monocytic component, promanocytes to monocytes, are less than 20% of non-erythroid cells, and other criteria for AML M4 not met. Blasts are positive for myeloperoxidase and Sudan black B. M2 blasts are also typically positive for CD13, CD33, CD15, and often for CD34, CD117, and HLA-DR. In AML M2, peripheral blood usually demonstrates anemia, thrombocytopenia, neutropenia, and variable number of blasts with or without granules. Blasts are often predominantly type 2, and/or rods may be present. Dysplastic features, such as hypo or hypergranularity or abnormalities of nuclear shape are common in the differentiation granulocytic component. Eosinophils and basophils may be increased. Such cases may be designated M2EO or M2 baso. Peripheral blood film of a patient with AML M2 showing a type 2 blast and a hypergranular neutrophil. Peripheral blood films of a patient with AML M2 showing dysplastic neutrophil and band form. In AML-M2, bone marrow cellularity is variable. Blasts comprise 20% or more of bone marrow nucleated cells and less than 90% of non-erythroid cells. Neutrophilic component is 10% or higher, and monocytic component is less than 20%. Or rods may be present. Some cases show dysplastic features in the maturing precursors. Bone marrow film of a patient with AML-M2 showing blasts type 1 and type 2, 3 myelocytes and a plasma cell. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.